we will discuss about bias and confounding, what they are, and how we can reduce them in epidemiological or clinical studies. So the objective of today's presentation is to define bias, what bias means in studies, to describe the different types of bias, to discuss how to reduce bias, and to describe confounding and understand the different ways of detecting confounding, and discuss commonly used methods of choosing a potential confounder in a study. So bias in a study is a systematic error in the design or conduct of the study that leads to an erroneous association. So when a study is conducted, usually we look at whether there is an association between two variables. The variables can be an exposure and outcome. It could be two different variables. And so an association might result, might exist or may not exist. And so bias is a systematic error. So we have a systematic error which can occur due to bias, and there can also be a random error. We will look at what random error means later on. So bias is systematic error in the design or conduct of the study that leads to an erroneous association. Bias can drive the association towards the null or away from the null, where the null means there is no association between the two variables that are being studied. So bias can result in incorrect or invalid association. It can increase the measure of effect size. It can decrease the measure of effect size. It can result in erroneous decision about the relationship between the two variables or variables. Bias in epidemiological studies occur due to either ignorance or unavoidable decision. Yeah.
The slides aren't moving forward on the.
They are not moving forward.
Your screen sharing is paused.
Yeah.
Yeah.
Resume.
Yeah. There we go.
So bias can affect the magnitude of an association. It says that if there is a strong association between two variables, the impact of bias is said to be minimal according to Ashangrao and CH3. If there is a strong association, the impact of bias is minimal. But if there is a weak association, the impact of bias might be huge. A bias might pull the association towards the null or away from the null. So when we say towards the null, for example, if we are comparing two means, the null is like the difference between the two is 0. So pulling the association towards the null means the effect size or the magnitude of the difference gets closer to 0. Away from the null means it's farther from 0, like towards the positive or negative. If we are comparing relative risk, the null is about 1. And moving the association towards the null means the magnitude of the effect size become closer to 1. And when we say move away from the null, it means the magnitude increases towards more than 1 or it's less than 1. When it's less than 1, it means as 1 occurs, the other, like that, as the risk in one increases, the risk in the other, kind of like a protective effect. So if we are saying, like, for example, looking at the association between air wearing protective ear devices and ear hearing loss, wearing the protective hearing device is a protective, reduces the risk of hearing loss. So the relative risk usually becomes like if one wears the protective hearing devices, the risk of hearing loss is reduced. That means the relative risk is below 1. But smoking increases the risk of coronary heart disease. So the relative risk of having coronary heart disease in a smoker compared to non-smokers is higher. And so when we say bias pulls the association towards the null, in this case, it means towards 1, and away from the null means either way less than 1, between 0 and 1, or higher than 1. So, for example, if the relative risk is 3, a bias might result in a relative risk of 2.7 or 3.2, can increase or decrease. The amount of bias might be small, it can be moderate, it can be large. And so bias is reduced when the study is carefully designed and conducted. And once bias happens, very little can be done to reduce a bias or to remove bias once that's occurred. So bias occurred during the selection of study participants or during the collection of data. And so once you have collected, there is almost very small, you can't do much thing to change the bias once that's occurred. So there are 2 common types of bias, endocrinological studies and clinical studies. One is selection bias and the other is information bias. Selection bias occurs during participant selection or follow-up, while information bias occurs during data collection. So selection bias is an error, a systematic error due to systematic differences in the characteristics of the participants selected into the study and those who are left out. It happens in case-controlled study if the selection of cases and controls depends on different criteria that's related to the exposure. So in case-controlled studies, we start with case, those with certain disease, and control, those without the disease. And we compare their risk of exposure to an exposure of interest. If the controls are selected based on a different criteria than the cases, and that means that there are differences between the cases and controls besides their disease definition, that can result in changing the measure of association at the end. So in retrospective cohort studies, if participant selection is based on the outcome of the study, again, a bias can be introduced. A selection bias can be introduced. So control selection bias, for example, healthy control for hospital-based study or general population for occupational study. So for example, if we select our cases from hospital and select the controls from healthy population, these 2 study groups might be different due to other factors. They might have like those who are ill and hospitalized might have other characteristics which is basically different from the control. That means the control does not represent the source population for the cases. In that situation, we are introducing some bias. Again, taking general population for occupational study, people who are like working in the construction or road industry. They tend to be very healthy and very strong. And if you take the general population as the control for that group, you are kind of like comparing different items, like comparing apples to bananas, something like that. So you want to avoid that kind of introduction of bias while selecting the control. Other examples of selection bias is refusal. When you design your study and want to collect data on participants, some might, based on their status, they might want to refuse. Some might say, I don't want to participate. And if their refusal is based on the exposure or outcome of your study, that can introduce again bias. Non-response is a similar one. Non-response and refusal mean you can still communicate with the participant, the potential participant, but they refuse to participate. In case of non-response, there is no response. You send mails, they are not responding. And if the non-response is different between your compared groups, that can introduce bias. Self-selection or voluntarism is another way bias can be introduced into a study. Loss to follow-up are related to exposure or disease. If it occurs, for example, differential loss of follow-up can result in bias introduced into the study. So, for example, here we are looking at observed relationship between talcum powder and the risk of cancer. This is a hypothetical data. And in the first table, it's unbiased. There is unbiased controlled selection. So the controls in the first tables were selected both from homes, from workplace, and from internal medicine wards. So there is a high representation of the population. And the odds ratio of exposure to talcum powder and those with cancer to the control was from this table about 1.84. This is hypothetical. It doesn't mean this is a reality. But in the second case, there is a biased control selection. In this case, the case were selected from cancer wards, while the control were selected by canvassing homes from Monday to Friday. So in the first case, controls were selected both from workplace, from home, and from internal medicine ward. In the second case, they are selected only from home during Monday to Friday. And if you can find participants at home from Monday to Friday, those kind of population might be different. You can assume they are unemployed, and with that, they might not have insurance, and they might not have even gone to health facilities. So they have no much exposure to talcum powder. But you are trying to control their risk of exposure to talcum powder. And in the first case, they were selected both from an internal medicine, which might have been exposed to talcum powder as well. And so, in this case, the odds ratio of exposure to talcum powder and those with cancer to the control was about 3.16 as compared to 1.86. And so, in this case, the bias of control selection drove the association away from the this one is another example of selection bias. So in the first table, there is an unbiased response rate. That means we have equal response rate in the exposed and non-exposed in the cases, as well as equal response rate in controls and those exposed and non-exposed. And so the proportions are the response rates and there is no self-selection bias. And the response rates are equal among exposed and non-exposed by status. And the second table, there is a response rate, but there is a biased response rate in the cases. Still, we have about equal response rate in the controls, while under the cases, about 85% responded to the maybe questionnaire, while only about 60% responded in the non-exposed group. That means there is the cases, exposed cases more responded to the questionnaire than the non-exposed cases. This can result in a biased result. So there is a self-selection bias in this case, and the response rate among cases is not equal by XOE. Another type of selection bias is differential surveillance, diagnosis, or referral. So based on studies, an example is based on studies that reported association between contraceptive pills and thromboembolism. Physicians admit patients with symptoms and signs of and histories of oral contraceptive use. So if another study is conducted, a case control study is conducted, find this about 10-fold increase in risk of thromboembolism among those who use OCP by selecting patients from hospital, there is already a selection bias in this case. What this means is there are previous studies that have been published that have found an association between oral contraceptive pill use and the risk of thromboembolism. So the physicians are aware, and they, like, if a patient has some signs and symptoms of thromboembolism and a patient has a history of OCP, they are more likely to admit that patient. And if you conduct your study among those patients and you are looking at the association between OCP and thromboembolism, there is already a selection bias based on the previous studies. There is already like an association, like the patients with signs and symptoms of thromboembolism were not admitted independent of the history of OCP or oral contraceptive use. So this creates a bias and can result in the association between OCP and the history of the thromboembolism if a study on this exposure and outcome is conducted. And selection bias occurs in cohort studies if the selection of participants is related to the outcome, or if there is a differential loss to follow-up that's related to the exposure or outcome occurs. Non-differential loss to follow-up. Non-differential, when we say differential loss to follow-up, it means so for example, in cohort studies, we start with those exposed, those not exposed, and we follow up the participant for an outcome. And if the loss to follow-up happens only, say, in those non-exposed or in those exposed alone, and it doesn't occur to the same or equally, it can result in a bias again. So non-differential loss to follow-up means there is a relatively equal number of people from those exposed and non-exposed who have been whom we have lost contact of, or those with a disease, like those with outcome. If equal number of people with disease are lost from those who are exposed as well as from non-exposed, this results in reducing as absolute risk, but does not result in a biased relative risk. But differential loss to follow-up bias is both relative as well as absolute risk. So when we say absolute risk and relative risk, absolute risk is on the additive scale. So the risk in the exposed minus the risk in non-exposed gives us the absolute risk. And relative risk is the risk in the exposed divided by the risk in non-exposed. That results in the relative risk. So information bias, so we've been talking about the selection bias. Information bias is another type of bias. It's a systematic error in the accuracy of the definition of exposure and outcome, or the measurement of exposure and outcome. Information bias can result in misclassification. Misclassification means classifying a person who is not exposed to as exposed, and classifying a patient, a participant who did not have an outcome as having an outcome. So information bias can result in misclassification. It can bias association towards or away from the norm. It happens after a participant enter the study. The common examples are recall bias. Recall bias usually occurs in case control studies. So cases tend to recall their exposure styles better than non-cases because they want to attribute their disease to certain exposure of exposure. This is called a recall bias, and that's very common in case control studies. Another one is interviewer bias. So while collecting data, if the interviewers ask a lot of questions and like dig deep in certain group as compared to the other, this can again produce information bias. So collecting data from cases and controls, or from those exposed and non-exposed differently based on the participant study or exposure results in information bias. Misclassification bias actually also includes the recall bias. Misclassification bias is one type of information bias. Actually, it's the most common type of bias. So misclassification means there is an error in the classification of participant as exposed or non-exposed, disease or not. Recall bias results in misclassification of exposure, especially in those in the controls. So disease misclassification can occur due to a broad definition of the disease or due to employing non-diagnostic techniques. So if we say cardiovascular disease, it can be a lot. It can be hypertension, it can be coronary heart disease, it can be stroke, it can be heart failure. But if we are referring to coronary heart disease, there might be a better definition of what that means is. So broad definition of a disease can result in a misclassification. And while looking at the association between variables, and can introduce bias in the association between the study variables. The misclassification is divided into two, differential misclassification and non-differential misclassification. Differential misclassification means one group has more classification errors than the other group, and it can bias result toward or away from the norm. Non-differential misclassification is classification error that occurs to the same extent in the compared groups, and the results, biases result towards the norm. The association result towards the norm. In the differential misclassification, this introduces more bias, more errors than the non-differential one. The non-differential one usually bias is the result towards the null, while this one can bias in both directions. So, and in this table, the first one is there is an accurate classification of those who are exposed and non-exposed. The relative risk is about 1.17. In the second table, there is differential misclassification. So, like in the exposed, in the first table, 150 of the ones who are exposed are said to have the disease. But in the second table, about 185 more participants are diagnosed with the disease and less with no disease. So there is a differential misclassification in this case. So some are like the ones who are exposed are said to have more disease, but the non-exposed ones remained 140 and 350. So this is the type of differential misclassification and result in the relative risk of 1.44 as compared to 1.17. So this means the bias that introduced due to the differential misclassification drove the result or the association away from the null. So far we looked at the two different types of bias. One is selection bias and the other is information bias. Selection bias, we say, occurs during study participant selection, and the information bias occurs during the data collection and the definition of exposure and outcome. And other types of bias in studies are the lead time bias, and this occurs when the survival time seems to have increased in patients diagnosed with the disease at early stage during the screening. So, like if a screening is done and the efficacy of the screening is evaluated by looking at the survival time of those who are screened and those who are not, those who have who've been screened seem to have an increased survival time. And this kind of difference that's introduced or that's introduced is called lead time bias. Compared to the survival in the regular healthcare setup, the screening-based diagnosis seems to have increased the survival, and this is called lead time bias. Another one is longest bias sampling. This occurs again when a screening detects disease with long subclinical course and better survival. So if a screening detects a clinical condition, for example, if we are screening patients for prostate cancer, and based on like prostate specific antigen, and we detect those with elevated PSA and follow up these patients, they might seem, those who have been followed up because they were detected early have a better survival than one who were detected at the clinic. That kind of bias that's introduced due to screening early in those with long subclinical course and better survival is called longest bias sampling. So unlike other biases that occur in regular studies, lead time bias and length bias sampling occur in screening evaluation studies. Another one is called publication bias. Publication bias usually occurs due to decisions that researchers make about whether to publish their study or not. So based on whether they found an association, based on whether the finding of their studies is according to their research hypothesis, sometimes researchers want to continue and go publish their manuscript or just to trash it. Especially when they don't find an association between the variables that they are interested in, they want to just trash it. And those kind of, so we end up with only studies that find association between the variables that are studied. Those kind of things result in publication bias. Those studies found in negative association are trashed. They are not published. Studies finding positive association or association between the variables which are studied result in publication. And this kind of things introduce publication bias. And the public might always get the same kind of information while there is other type of information that have been not used, not publicized or disseminated. So how to reduce bias? In case control studies, one has to select cases and controls based on the same criteria. Using the same criteria, if we are selecting our cases from hospital, it's better to select the controls from the same hospital as well, or select from the population from which the cases came to the hospital. Select the control participant that reflect the distribution of the exposure in the source population, of the case. And in cohort studies, select the exposed and unexposed based on the same criteria again. Maintain high and similar follow-up in the both exposed and unexposed. Collect baseline data on contact address and information to locate participants for a complete follow-up, and maintain regular contacts, update participant on the progress of the study to ensure participants still provide information about like the outcome, and check numerous tracing resources like a post office and the likes to maintain contact with the participant. Instruct interviewers on appropriate data collection techniques and make sure that the interviewers are collecting the data in the same way from those compared groups. If they ask deeper in certain group compared to the other group, they can introduce bias. So make sure you train the interviewers to collect the data appropriately using the same techniques. And mask participants to the study hypothesis. So for example, in the case of recall bias, if you let your participant know that you are studying this outcome and exposure, especially those with cases, the disease, better remember their exposure to certain exposure of interest. So mask the participant to the study hypothesis, what you are trying to find, and mask the interviewers to the study hypothesis as well. And use multiple sources and multiple measurements. So if you are measuring exposure one in terms of like the cohort studies, usually there might be measurements either at the beginning. If you don't measure again and take an average, you can introduce certain bias. So try to make multiple measurements. Use most common accurate source of information. And sometimes family members and proxies might provide information. It's better to collect data from the participants themselves rather than from proxies to get a more accurate information. And use sensitive and specific criteria to define exposure and disease. Yeah, thank you. So the next one is confounder. So we say bias is a systematic error that's introduced during study participant selection or during data collection. But a confounder is it's a search variable. It's a naturally occurs. It's a search variable that distorts the relationship between the exposure and the outcome. While confounding the mixing of effects between exposure and the outcome of the disease, and the third variable that is determined the confounder. So naturally exists in epidemiological studies and clinical studies conducted among free living participants. To say a variable is a confounder, it has to be associated with the exposure and the outcome. And ideally, a comparison is made on the outcome of participants when they are exposed to the exposure had they not been exposed. That means ideally to avoid confounding or the effect of a third variable, you would compare the participant to their own self. So you want to like compare the disease risk when they are exposed, but you want to like compare to themselves had they been not exposed to the exposure. Like you want to compare like the risk of certain cancer in those who are smoking had they not been smoking. That naturally that does not occur, but it's called a counterfactual concept. It does not occur. So what that means is you want to avoid all sorts of confounding, another variable that might distort the association between the two variables. So you want the age of the participant about to be the same of the group that you compare, gender to be the same, maybe blood pressure to be the same, many other variables to be the same. So only randomized controlled trials can take care of, can resemble a counterfactual concept. It can evenly distribute the confounders between the compared groups because the participants are randomly selected. Some epidemiological or statistical techniques can mimic the counterfactual effect by creating the exposure or outcome of the participant who are followed. So confounding occurs when the comparison groups fail to reflect their counterfactual of the other group. So when two groups are compared, if they are disliked, if they are not alike, if they are not similar in other risk factors, then there is basically a difference between the two groups and you are comparing two groups. And so this introduces confounding. We'll see some examples. And so confounding occurs when the comparison group fails to reflect the counterfactual of the other group. When these factors are non-evenly distributed among the compared groups, confounding exists. For example, the relationship between body mass index and the risk of type 2 diabetes varies by age, by gender, and might vary by other factors as well. So age and gender in this case are confounders. So how to detect confounding? One, examine if there is an association between a potential confounder and the outcome, and examine if the association is different by the exposure status. So you should examine if there is an association between the potential confounder and the outcome, and check if the association is different by the level of the exposure, and examine if there is an association between the exposure and the potential confounder. And you can use a bivariate analysis to examine the association. So an example of confounding, and the menopausal status are the potential confounder on the association between obesity and the risk of breast cancer. So in the first table, this is a crude analysis. We didn't take into account menopausal status. And we have about 300 breast cancer cases who have BMI greater than 30 kilogram per meter square, and about 150 among those with BMI less than 30. And in the controls, we have about the same. And the crude odds ratio of BMI, in this case obesity, is about 2. So this is a crude analysis. And when we adjust for menopausal status, in the premenopausal participant, we have the same number of those above 30 kilogram per meter square. So we divided into 2. We have 110 of them in the premenopausal group and about 190 of those in the postmenopausal group. And about 100 breast cancer cases in those below 30 kilogram per meter square. And the odds ratio of the obesity in the premenopausal group is about 0.85. That means high body mass index in this case is protective of breast cancer risk. While in the postmenopausal patients, the odds ratio is relatively higher, about 4.75. And that means there is a differential association between obesity and the risk of breast cancer based on the menopausal status. And this tells us that menopausal status is a compounder in the association between obesity and the risk of breast cancer. So one way to look at whether a given variable is a compounder is look at the crude association and conduct a stratified analysis and compare the two relative risk odds ratio. And if they are different based on the level, and as well they are different from the crude one, that's an indicator of confounding. So the general rules in detecting a confounding in multivariate model, confounding is if the magnitude of association changes by more than 10% based on the adjustment of any variable. So when you calculate your beta values, if you compare the beta values after adjusting the variable, if the beta value changes by more than 10%, it means the variable that you adjusted is a compounder between the association, the compounder of the association between the two variables. Determine if the exposure outcome association seen in crude analysis has the same direction and similar magnitude as in the strata of the potential compounder. If so, the variable is not a compounder. If the magnitude and direction of the estimated relative risk odds ratio seen in the strata of the potential compounder is if similar in magnitude as well as direction, there is no compounding. If they are different, I mean, that's an indicator of the compounding. Does the exposure outcome association in crude analysis remain after adjusting for the potential compounder? If so, the variable is not the compounder. The potential compounder should not be an intermediate in the pathway of association. So some variable can be, for example, cholesterol. Cholesterol is on the pathway between the cause for cardiovascular disease and maybe stroke. So you don't adjust for intermediate. If you adjust for intermediate, you are blocking the route of association between the two variables. So make sure the third variable is not an intermediate between a given exposure and outcome.
Matt, do you want questions to be held for the end?
Yeah.
Oh, do you know? Okay.
Yeah.
Okay.
At the end, we can go back and look at the slides.
Okay.
So the commonly used methods to select a compounder are based on the literature and theoretical considerations. Even if sometimes the set variable does not have a p-value less than 0.05, you still decide to keep the variable in the model based on the literature and based on theoretical considerations. And age is one of the common compounder. Usually, in epidemiological studies, age is almost every time is suggested as a potential compounder. Gender is the same. There are many other variables that are usually adjusted, and socioeconomic status can result in differences in association between a given exposure and outcome. So you select a compounder to include in a model based on literature and theoretical consideration, based on univariate analysis, looking at the association between exposure and the potential compounder, outcome and the potential compounder, stratified analysis. And the third one is automated, using the stepwise selection criteria. In SAS, you would include selection as an option on the model statement, and enter SL enter and SL stay options, and it varies between, so the P, this stands for P values, but varies between 0 and 1 inclusive. So some use 0.1 as LS enter or stay, some use 0.5, all depends. And the other one is using a forward selection criteria. This means you select a variable that meets a given SL enter, which is again between 0 and 1. And once the variable enters into the model, you keep it, you don't remove it. So you just need SL enter. And using a backward selection criteria, in this case, you will enter all the potential compounders into the model, and who meet certain you enter all of them and keep only those who meet the threshold criteria. So you can select compounders based on literature and theoretical consideration, based on univariate analysis and outcomes. So internal validity of a given study. Internal validity means within the study population, within the compared groups, the validity of the result, the association that you found, depends on these at least 3 factors. So a study is considered valid only when alternative explanations such as bias, confounding, and random error are considered. So we mentioned about random error at the beginning. Random errors is usually the probability that the observed association is actually due to a chance alone. Usually, we set a critical value or a significance level, which is 0.05, and you say if my p-value is less than 0.05, there is a significance association. That 0.05 critical value or alpha value is that is the one that you set for a chance. So if the probability of a chance describing the chance explaining the association that's observed is less than 1 in about 20 or less than 0.05, I would still consider this an association. So the probability that the chance explains the association that's observed is very minimal. It's less than 0.05. And that can occur. Like one in every 20, and a chance can explain the association that's observed if you decide to use an alpha value of 0.05. There is still a risk, like in about five of 100 studies, there might be 5 that the association actually just happened by random association. Thank you very much for your attendance. Yeah, so this presentation is sponsored by TN-CTSI Clinical and Translational Science Institute.